So we're going to move next to heart failure with preserved ejection fraction. Dr. Barry Borlaug is going to come up to the podium. First, we have a few pretest questions here, so let's pull up his first question. So in patients with invasively proven HFpEF referred to the cath lab, NT-proBNP are less than 220 in what percent of patients? 0, 10, 20, 60? Okay, 43% said 20%. Question number 2, 60-year-old male has obesity with a BMI of 40, type 2 diabetes, hyperlipidemia, sleep apnea, dyspnea with minimal exertion, no edema or S3. JVP tough to assess. His EF is 65% with mild RV enlargement and dysfunction, normal left atrial volume, ED prime 10. Pulmonary artery systolic pressure 60, chest x-ray normal, cath normal, mild restriction on PFTs with a normal DLCO. What do you do? VQ, NT-proBNP, right heart cath with exercise, cardiac MRI, or a PYP. Dyspnea with minimal exertion. Okay, 50% said right heart cath with exercise. Question number 3, 71-year-old woman with history of AFib, breast cancer, pacemaker, and CABG presents with worsening dyspnea. On exam, neck veins JVP 14, early diastolic sound and 2+ edema. Echo shows EF 60% with abnormal septal motion, lateral ED primed of 13. NT-proBNP is 127. What should you do? Spironolactone 25 daily, shoot the coronaries and grafts, left and right heart cath, cardiac rehab, or DAPA 10. %46 said left and right heart cath. All right, question 4. 60-year-old woman hospitalized with heart failure improves markedly with IV diuretics and is discharged on furosemide 40 milligram daily, atorvastatin 10, and lisinopril 10. She now reports dyspnea walking up one flight of stairs. Echo shows an EF of 62%, RVSP 65, mildly dilated IVC, and moderate central mitral regurgitation. Exam shows BMI 32. Blood pressure 126/76, heart rate 72, JVP 10, clear lungs, no gallop, soft apical systolic murmur. What should you do? Spironolactone 25, start sildenafil 10 milligram TID, increase to 20 milligram TID if tolerated. Start DAPA 10, discontinue lisinopril and start sacubitril valsartan, and titrate to 93/103 milligram twice daily. Get a TEE to better look at the MR, or start semaglutide once a week. All right, Dr. Borlaug is coming to the stage. See how we did on this. So 45% said DAPA 10. All right, looks like we have some gaps in knowledge here to fill, Dr. Borlaug. So Dr. Borlaug is an international expert in heart failure with preserved ejection fraction. He is the research chair for the Department of Cardiovascular Medicine and an NIH-funded researcher. He has really done groundbreaking work in this field and is an excellent educator with regards to heart failure with preserved ejection fraction. Thank you very much for sharing your expertise with us.
Thanks, Mike. Good morning, everybody. My pleasure to talk about HFpEF with you. Hopefully we'll get the nice lift on those questions. These are my disclosures. And in the next half hour or so, these are the two things we really want to do. Understand better how to evaluate and diagnose patients with suspected HFpEF, rule it in and rule it out. And then we'll spend more time on how to treatment, which used to be a really short discussion, but is now getting longer and longer. So just to review, we've said for years that about half of all patients with heart failure have a normal ejection fraction defined by 50% or greater, but that's really changing. And now it's pushing closer to 60%. So this is really, in the United States, becoming the dominant form of heart failure over heart failure with reduced ejection fraction. The incidence is similar in men and women, but men have shorter lifespan after diagnosis of HFpEF, and women live longer than men on average, and HFpEF is associated with aging. So when you look cross-sectionally, about 2 out of every 3 patients with HFpEF is a woman. The overall prognosis is a little bit better compared to heart failure with reduced ejection fraction. But the great equalizer is hospitalization. So once a patient with HFpEF gets hospitalized, their outcomes are abysmal, and only 1 in 4 is alive at 5 years, and that's no different from heart failure with reduced ejection fraction. So it's a big, massive public health problem, and it is really growing. So I think it's important first to step back and talk about what it is. We all have this intuitive sense for what heart failure is, but how would you objectively define it? That's really important to understand. And this is a modification of sort of the classical Braunwald definition. So it's signs and symptoms, breathlessness, fatigue, that is related to an inability of the heart to pump blood adequately to the body to meet its needs, or to do that only at the cost of high filling pressures. This is a very important definition because it includes objective, measurable criteria. This has been updated more recently with the so-called universal definition of heart failure, which really is pretty much the same thing. It's signs and symptoms, it's due to a cardiac abnormality, and it's corroborated by some objective evidence of congestion. And in the universal definition, they say either elevated natriuretic peptide levels or other objective evidence. So how do we make this objective assessment? We can do it through simple things like physical exam, so findings like jugular venous distension or third heart sounds. We can do it with laboratories like BNP or NT-proBNP, chest x-rays showing cephalization. We can do it with echo. We can look for things like the high E to E prime ratio, which is a surrogate measure of left heart filling pressures, or dilatation of the IVC. But when all of this is equivocal or non-diagnostic, that's when we need to take patients to the cath lab to get the real answers. So here's a 70-year-old lady with dyspnea, and she's got a normal EF, and she's got some risk factors for HFpEF. She can't lie down because she's short of breath. Her jugulars are at the earlobes. She's got a third sound. She's got curly B lines on her chest x-ray. Her echo shows massive pulmonary hypertension and high surrogate markers of high right and left heart filling pressures, and she gets better with diuresis. This is easy. You don't need to do all this other corroborative testing to make the diagnosis. This is clear-cut HFpEF. Clinical diagnosis that you can make in the office or on the wards. But here's another 70-year-old lady. She also has the same EF, she has the same risk factor profile, but her symptoms aren't quite so fulminant. It's more activity living, activity altering, class 2 to 3 symptoms. She's never been hospitalized with volume overload. She's never come into the ER. In clinic, she looks pretty euvolemic, and she has a normal BNP. And of course, you get an echo, and there's a little bit of left atrial enlargement. The EE prime ratio and the right ventricular systolic pressure estimates from the echo are not clearly abnormal, but they're also not totally normal. So what do you do with this kind of patient? This is the kind of patient that in this era really needs to be referred for exercise testing, and that's what was done here. So here's her left ventricular pressure in red and her pulmonary capillary wedge pressure in black. And you can see they're stone cold normal, 12 millimeters of mercury. So you've done your job, right? Physical, labs, chest film, and a cath. It's all normal. It's not HFpEF. Well, she's not symptomatic at rest. She's symptomatic when she does things. So we can't make any conclusions about whether she does or doesn't have heart failure based on resting data alone. Just like you wouldn't tell somebody with crushing chest discomfort with activity that they don't have coronary disease from a normal resting ECG. So we need to stress the cardiovascular system to bring out these abnormalities, and that is what is done. And here is what happens with just 40 watts of exercise. This is a very low workload, and now you can see that her wedge pressure and her LV diastolic pressure are 40. So this is HFpEF. This is somebody with HFpEF. We could only make the diagnosis when we took them to the table of truth in the cath lab. And this is a series we published a number of years ago now, patients just like this. Indeterminate dyspnea, normal EF, normal BNP, pretty vanilla looking echo, and when you take them to the lab, a little over half of them will have hemodynamic derangements that are diagnostic of heart failure. So important point here, and this was one of the questions, so we'll see a nice lift here. Normal NT-proBNP does not exclude HFpEF. It does not. This is a study where we looked at invasively proven HFpEF, and 37% of them had an NT-proBNP less than 125. 60% had an NT-proBNP less than 220. So you can't use these as rule-out tests. They are lower in HFpEF than HFrEF, and they are very frequently normal. Part of this is related to the smaller heart size. Part of it's related to the high burden of obesity that we see in these patients. Now, higher NT-proBNP is clearly associated with increased risk of heart failure, hospitalization, or death. That's shown with the red curve. But even the patients with totally normal NT-proBNP have a 2.4-fold increased risk of heart failure, hospitalization, or death. So we can't use this as a rule-out test. What about the E to E prime ratio? So from echocardiography, this is the ratio of the transmitral early Doppler inflow to the tissue Doppler E prime velocity, and this is correlated with filling pressures. Moderate correlation, you can see that here, it's been shown repeatedly. So it is helpful. And this is a comparison of patients with HFpEF, their E to E prime ratio, versus NCD as non-cardiac dyspnea. And you can see each dot as a patient. These distributions of data are very different. P-value is highly significant, but you can also see, and I'm not sure how well it shows up here with the gradation, but there's a lot of people with HFpEF with a normal E to E prime ratio. So if the value is high, the specificity is high, you can usually take that to the bank, but you can't use a low or normal EE prime ratio to exclude HFpEF. Same thing as with NT-proBNP. And we see the same thing with left atrial volume, which is another indicator of filling pressures. So invasive exercise testing has really emerged as the gold standard to make the diagnosis or to rule it out, but it's not appropriate to do this in everybody. So we need a system to help us prioritize and inform medical decision-making about who should get an exercise cath and who shouldn't. And that was the impetus for us coming up with this, what's called the HFpEF score. So this is a score, and it's been out now for a couple years, so it should definitely show up on the boards. Very easy to apply. So what we did is we took a large series of several hundred patients who had undergone this invasive assessment, and we categorized them according to the gold standard as HFpEF or not HFpEF. And then we looked at all the characteristics that were not invasive that could help us to separate these two. And the things that come out as being significant predictors are included in the final score here. We've got 6 variables, 4 clinical, 2 echo Doppler. You can see that any history of AFib is 3 points, and obesity is 2 points. So the score ranges from 0 to 9, and the beauty of this, to me at least, is that it allows you to estimate the probability that somebody that you're seeing with dyspnea and normal EF has HFpEF. So the nomogram on the bottom shows you this. If the score is 6, 7, 8, 9, it's 95% likely. You can pretty much take that to the bank. If the score is 0, it's very unlikely. If it's in between, that 2 to 5, that's the intermediate pretest probability. That's where you really want to prioritize additional testing with invasive exercise testing. Now, a year after we came up with the HFpEF, the H2 HFpEF score, which was evidence-based, there was another score, the HFpEF score, which was expert consensus-based. This was from the ESC and published in the European Heart Journal a year later. It's much more complicated. It relies exclusively on echo Doppler and biomarker data. We compared the two. And the HFpEF score came out on top. You can see the area under the receiver operating characteristic curve is higher for the HFpEF score versus the HFpEF. And this was largely driven by greater sensitivity. So you can see on the right side there that a lot of patients with a so-called low risk or rule out HFpEF score actually ended up having HFpEF. So I think that that's probably the easier one to use and it works better. This is brand new. So it's not on your boards if you want to tune out for a second, but if you want to learn a little bit more, this is called the HFpEF ABA score, and we just published this earlier this year in Nature Medicine. It's like the HFpEF score, but you don't need the echo. And the advantage here is it can be very helpful for screening in EMRs. So it's only based on three things: your BMI, whether you have a history of AFib, and your age. It turns out those three things are very informative in determining whether or not you might have HFpEF. These are the ROC curves. You can see pretty good discrimination of patients with HFpEF from controls. So higher age, greater BMI, and then a history of AFib, strongly associated. And it's not just diagnostically accurate, it's also prognostic. So patients with a higher probability, the probability is what it ranges from 0 to 100 that comes out from this score, and you can see that that's strongly associated with increased risk of heart failure, hospitalization, or death. So coming in the future, but not for your boards this year. Now, once you've made the diagnosis, like we did in those two cases, you need to step back and remember that not all HFpEF is HFpEF. Now, what do I mean by that? When I use the word HFpEF, I'm excluding all other things that lead to the clinical syndrome of heart failure that have a normal EF, but that are not HFpEF. So I am talking about things like this. So what are we looking at here? So on the left, you can see LV pressure tracing in red and an RV pressure tracing in blue. And going from the second to the third beat, the patient's taking a breath in, and the LV systolic pressure is going down, and the RV systolic pressure is going up. So what is this? Right, this is constriction. This is pericardial constriction. This is enhanced ventricular interdependence. And on the right-hand side, this orb around the heart is a calcified pericardium. So this is also heart failure, and the patient also has a normal EF, but it's not like start them on the SGLT2 inhibitor and move on. We need to refer them to a surgeon for a pericardiectomy, and we can cure them of heart failure. So it's really important, and this is really important for the boards. It's not enough to just say it's heart failure and the normal EF. You need to think about all the other causes. So some of these things are not what we call HFpEF. This is constrictive pericarditis. Here's another one. We see macroglossia. We see apple green birefringence. What are we looking at here? This is cardiac amyloid. So people often sort of conflate this with HFpEF or say it's a type of HFpEF. It's not HFpEF. It's cardiac amyloid. It's due to abnormal deposition of proteins in the myocardium. It has its own specific treatment, which is not the same as HFpEF. So we don't want to miss this. We can get this patient on tafamidis and potentially other treatments that are coming down the pike. Sometimes HFpEF is disguised. So here's an 81-year-old woman with dyspnea, and she gets an echo, and she has a really high estimated right ventricular systolic pressure on echo, so she's referred to the cath lab. And now in green here, you can see her pulmonary artery pressure tracing. She's got severe pulmonary hypertension, severe PH. So time to think about the endothelin antagonists and stuff like that. Well, let's get a little more information. Here in blue is her right atrial pressure tracing, severely elevated, about 18 millimeters of mercury. Here's her wedge pressure, or her surrogate for left atrial pressure. She's got a wedge pressure of about 22, very prominent V waves in the absence of mitral regurgitation. We give her some nitroprusside in the cath lab when we see pressures that are high, especially when there's systemic hypertension. We like to bring them down. And with that, we can see that her pressures get much better. They don't normalize, but they come down quite a bit. Now, this was a study from many years ago, or a case from many years ago, published in 2010. So at this time, the referring doctor in the PH clinic was thinking, well, maybe we could get them on a pulmonary vasodilator. So what happens if we give them some nitric oxide? So inhaled nitric oxide, a pulmonary-specific vasodilator. Now we take this pressure that looks like this, and we convert it to this. So now the PA pressure is basically the same. The transpulmonary gradient, the gradient from the PA to the wedge, has gone down, but that's because the wedge has gone way up, because now we've basically opened up the dam in the lungs, and now we're flooding that left atrium with blood. So the point here is that this kind of patient who has what's called combined pre- and post-capillary pulmonary hypertension, these people are also part of the HFpEF puzzle, and we should not be giving pulmonary vasodilators to them. Now, you'll hear talk about phenotypes in HFpEF. There are, it's not one size fits all. There are these different sort of phenotypes. There are some people with this obesity phenotype. We'll talk a little bit more about that. Some people have more RV dysfunction and tricuspid regurgitation. So there are these different phenotypes that we're beginning to understand. And part of it is related to a different phenotype, but part of it is also related to disease progression. So early in the course of HFpEF, the heart looks like at the far left. It doesn't look that abnormal. The LA is not that big. They just have isolated LV diastolic dysfunction. They may have normal filling pressures at rest that only go up during exercise, like in the case I showed you earlier. But as the disease progresses, we start to see worsening LA dysfunction, LA remodeling, start to get a little bit of a reduction in LV strain, start to get a little atrial functional MR. Maybe they're having intermittent AFib. Now the filling pressures are getting high at rest if you put the catheters in. Then that progresses along farther, and you start to get some pulmonary vascular remodeling. The PVR starts to go up. Now the right heart is starting to dilate. The right atrium's getting bigger. You're starting to get functional TR too, and that's really advanced stage of HFpEF. So there are different phenotypes that are related to different etiologies, but there's also different stages in disease progression that are important to understand. Now, this is just a table. I'm not going to go through this, just in your packet to kind of go through. These are all the other things that you should be thinking about other than HFpEF that you don't want to miss, especially in practice, for sure, and also for the boards. Some of these things, like valvular disease, coronary disease, or toxins, they can coexist with somebody who has HFpEF. So that becomes kind of a judgment call. Do they have heart failure from mitral regurgitation, or is it HFpEF that also has a little mitral regurgitation? That becomes something of a judgment call. So to summarize evaluation and diagnosis, we do look for things. We look for evidence of congestion from echo, high EE prime, high LA volume, high RVSP. We look at the BNP and the NT-proBNP. If these are high, that has good specificity. We can feel secure making the diagnosis. If they're not high, it doesn't rule out HFpEF. Very, very important, especially normal NT-proBNP or BNP. We assess the pretest probability or the likelihood. The easiest way to do it is with the HFpEF score, which you can calculate in your head at the bedside. There are other scores that are coming down the pipeline as well that you can consider. Patients with intermediate probability, they are the ones that need to go for a diastolic stress test. Cath is the best. People are trying echo. Echo is good also for positive predictive value, but not as good for a rule-out test. And remember, when you identify that heart failure is present in a normal EF, think about all those other non-HFpEF causes. Okay, so let's talk about treatment. So treatment for years was just diuretics and comorbidities, and treat comorbidities, which is, who wouldn't you treat a comorbidity on? It's kind of silly, I think. Diuretics, they're not going anywhere. They are very effective. And people say there's no evidence for diuretics, but in fact there is. This Kaplan-Meier curve comes from a sub-analysis in HFpEF patients from the CHAMPION trial. The CHAMPION trial was a trial where patients got an implantable PA pressure monitor. Everybody got it, and then half of them got randomized to treating them based on knowing the PA pressures. And the patients where we knew, or where the investigators knew the pressures, treated more aggressively, mostly with diuretics. And you can see here, much lower risk for heart failure hospitalization, huge effect. Number needed to treat of only 2 over a year and a half to prevent a heart failure hospitalization. So much more effective than a lot of the other treatments that we had back then. in 2020, like ARBs and Entresto and things like that. So definitely treat with diuretics for patients who are congested. Well, what about MRAs? Paul talked about that for HFrEF, strong evidence, and there was a lot of optimism that these would be effective in HFpEF. This was tested in the TOPCAT trial, spironolactone versus placebo. No effect. Did not reduce the risk of heart failure, hospitalization, CV death, or aborted cardiac death. There was a reduction in heart failure hospitalizations as a secondary endpoint, but remember that when you don't meet the primary, you have to treat that as hypothesis generating only. Now, subsequent to this, the investigators looked separately. About half of the patients in TOPCAT were enrolled in the Americas, in the Western Hemisphere, and then the other half was enrolled in Eastern Europe and Russia. And when they looked at the patients in Russia and Eastern Europe, they didn't look like they had HFpEF. They had very low event rates. There was little evidence that they were even taking the medicine that they were supposed to be taking. So when they looked only at the patients enrolled in the Americas, it was a positive trial. But it was post hoc, so people kind of interpret this differently, and this is what the guideline writers say. They give it a 2B indication. That means we can consider it. We should think about using MRAs. So that's definitely something that we would think about, particularly once we've improved the other stuff, or when we've added the other more effective evidence-based treatments. Then came Paragon. So Paul also talked about Paradigm in HFrEF with sacubitril/valsartan. This was the companion study in patients with heart failure and preserved ejection fraction. They were randomized to sacubitril/valsartan or valsartan, so it's not a placebo control, it's an active control. And it was the narrowest of misses. A non-significant 13% reduction in total hospitalizations for heart failure or cardiovascular death. So close, and it's been, kind of, I don't want to say spun, but just like, well, should we really worship at the altar of P.05? I mean, it's pretty darn close, but the effect size is not really that dramatic. So this has got a labeling now from the FDA that they've removed the qualification that you have to have a low EF, and this is what the guidelines say. They also give it a 2B. So it's something we can think about for HFpEF, but it's not really strong evidence-based medicine. Then came the SGLT2 inhibitors, and this has really changed everything. And we knew this from the diabetes trials by serendipity, that it reduced heart failure events, and then it worked in HFrEF, and then it was tested in HFpEF. First in the Emperor Preserve trial shown here, a highly significant 21% reduction in the risk of heart failure, hospitalization, or cardiovascular death. So at last, a proper outcome trial showing a benefit. These drugs have also been shown to improve quality of life. They also improve exercise function by 6-minute walk distance. Corroborated in a second outcome trial. This is from the Deliver trial. Same thing, about a 20% reduction in heart failure hospitalization or CV death. So we finally have very strong evidence-based treatment. So this is really the cornerstone of treatment for HFpEF, the SGLT2 inhibitors. And Paul actually had this slide in the HFrEF talk. This actually comes from the HFpEF study. The effects are very early. After just 18 days of treatment, there's a reduction in the risk of heart failure hospitalization. So these work right away. They work in the hospital. They reduce the risk of ICU stays for heart failure. They reduce the risk for outpatient escalations of oral diuretics. These are super, super effective drugs. They work in the setting of decompensated heart failure. This is from a study called the Soloist trial of sotagliflozin, which is a combined SGLT1 and 2 inhibitor. Very dramatic reduction in the risk. They included patients with both HFpEF and HFrEF. The benefit was just as great in HFpEF. This is another trial called MPulse, empagliflozin, same thing. Win ratio, looking at a combined endpoint of death, heart failure, hospitalization, or quality of life, significant win. Benefit just in HFpEF, just like it is in heart failure with reduced ejection fraction. And then this is the meta-analysis, which was published just after the Deliver trial was published and presented in 2022. Again, showing combined very strong evidence of a signal across all the trials. Almost a reduction in CV death. You can see that the p-value just misses 0.05, nominally significant 12% improvement or reduction in CV death. It's not just HFpEF between 50 and 59, it's also 60 and above. So it's not even the really high EF patients also benefit. And these drugs are really safe. Paul talked a little bit about some of the things we worry about with type 1 diabetics and mycotic infections, but those are usually pretty easy to detect. So this is really safe, does not cause hypoglycemia in the absence of insulin or other things like that. So this is foundational treatment that we should be giving. Now, these were really identified by serendipity. What are the mechanisms? And now we're working to try to figure out what that be. This is a study a mechanistic trial, very small trial, where we did invasive hemodynamics to try to figure out what's going on with these medicines. So what we did is took patients with HFpEF, mostly obese HFpEF, and they underwent invasive hemodynamic exercise testing, like the case I showed you earlier at baseline. And then they were randomized to dapagliflozin or placebo for 6 months, and then they came back and had another exercise test along with some other assessments. And the primary endpoints were resting wedge pressure and exercise wedge pressure. And here's the data. Here's what we see after 6 months. So each dot is a patient, and you can see the mean. There's no effect of placebo on resting wedge pressure or exercise wedge pressure. But as compared to placebo, there's about a 20% reduction in resting wedge pressure and an even greater magnitude reduction in exercise wedge pressure. So these medicines are effectively decongesting patients with HFpEF. The improvement in wedge pressure was correlated with the reduction in body weight. Now we know SGLT2 inhibitors do lead to some weight loss. It turns out if you're more obese, you lose more weight. And our patients in this US-based study were more obese, so they lost about 3.5 kilograms as compared to placebo. So those who lose more weight had a greater improvement. This was more strongly correlated with the hemodynamic benefits than changes in plasma volume. So it's not just like a smart diuretic, it's actually changing body composition. Here's some data that shows that. This donut plot shows the distribution of the kind of tissue that's lost when you give an SGLT2 inhibitor. It's mostly fat. And the reduction in fat, trunk fat, upper body android fat was correlated with the hemodynamic improvements. So again, pointing to the importance of this obesity phenotype, and we even see improvements in pulmonary vascular loading with these drugs. So during exercise, in particular, patients with HFpEF have pulmonary artery stiffening, a low pulmonary artery compliance, dapagliflozin improved PA compliance, reduced PA vascular stiffness or arterial elastance, and improved RV-PA coupling. And then they also improve systemic vascular function. So patients with HFpEF often have resting hypertension, and they especially have a hypertensive response to exercise. It turns out dapagliflozin really puts the brakes on that, attenuates that. There was about almost a 20 millimeter reduction in exercise systolic blood pressure, an improvement in arterial compliance, and an improvement in venous capacitance. And the reductions in blood pressure were correlated with the favorable hemodynamic effects. So these drugs are really incredible. They work through multiple different mechanisms. They clearly are associated with hemodynamic improvements, and we should be using them. So this is what the guidelines say. In the ESC guidelines, it's a class 1 for an SGLT2. The most recent AHA ACC guidelines, it was a 2A, but that's because they only had Emperor Preserved at that point. Since then, Deliver has been published, so I'm just going to modify this without permission and say it's a class 1. So definitely use these for the boards. Okay, so I talked a little bit about phenotype. So what about this concept of phenotype-derived therapy? The biggest phenotype, especially in the US, is this obesity phenotype. And when, obesity is really common in the US, as you all know. It's approaching 50% by 2030. And right now, about 2/3 of patients in the US with HFpEF are obese. And they have a lot of the same features as non-obese HFpEF, but there are some differences. They have increased pericardial and epicardial fat accumulation, like shown in this autopsy section. This leads to increased coupling and ventricular interdependence. The pericardium is restraining filling, and the right and left heart are sort of competing for space. So on echo, you see this septal flattening and D shape of the septum. They have more volume overload, so there's more of this positive correlation between their wedge pressure and the volume, the plasma volume excess that accompanies obesity. And they have these abnormalities abnormalities in venous capacitance. So you can estimate this based on what's called the stressed blood volume. The stressed blood volume indicates the amount of venal constriction that is present, and these patients have more of that. So that also exacerbates their hemodynamic abnormalities. So this was tested in a specific trial. This was the HFpEF trial, which was published last year in the New England Journal. And this took patients with obesity phenotype of HFpEF, so BMI of 30 or greater, and randomized them to the GLP-1 receptor agonist semaglutide or placebo, treated for 1 year. And the primary endpoints were quality of life by the KCCQ score, Kansas City Cardiomyopathy score, and body weight reduction. And as you could see here at the time, this was unprecedented. 8-point improvement in quality of life score, hugely significant effect. And then the other dual primary endpoint, reduction in body weight, 11% decrease in body weight. So this was a huge home run. We also looked at changes in 6-minute walk distance. That was improved by 20 meters. This was also an unprecedented effect. And about a 40% reduction in systemic inflammation as measured by CRP levels. So it's doing all the things that we want to be seeing. And when we looked, the degree of efficacy across all of these different domains was correlated with the amount of weight lost. So you can see this forest plot here on the top. This is plotting the degree of body weight reduction with the magnitude of improvement in KCCQ. And those patients who lost more weight had a greater improvement in quality of life. They had a greater improvement in 6-minute walk distance. They had a greater reduction in systemic inflammation. And that's shown here. This is the change in KCCQ in pink, 6-minute walk distance in blue, and CRP in green for each 10% reduction in body weight. So it really strong evidence supporting the causal role of excess body fat, that we really need to be targeting this. And this is really important because now we have newer incretin therapies, these combined therapies that lead to even more dramatic weight loss. So it's a really exciting time in the HFpEF field and the obese HFpEF field. HFpEF was followed up with a sister trial called HFpEF-DM. HFpEF was non-diabetics. Now this is only diabetics. It's the same thing. There's a little less weight loss in diabetics for a number of reasons, but it was another slam dunk. Across all the primary and confirmatory secondary endpoints, there were improvements. And then in the combined analysis, which was also published in The Lancet, we looked at the risk of heart failure hospitalization, and that was, there were not many events. These were not powered to be outcome trials, so there's only 38 events. But as you can see here with these Kaplan-Meier plots, there was a significant reduction in the risk of heart failure hospitalization. So really impressive with these new drugs. And recently, this is only a press release, so this is definitely not on your boards, but it's coming soon. I'm showing it because it's out there on the internet. The URL is down there. This is the results of the SUMMIT trial. And the press release indicated that the primary endpoint was met. There was a 38% reduction in heart failure events with tirzepatide, which is a different GLP-1/GIP agonist. So these are really coming soon, are really going to change the landscape. Okay. Last final steps here. What about AFib? AFib is really common in HFpEF. When you look at the whole course of life course of a patient with HFpEF, about 2/3 of them will have AFib at some time point. It's really, really common. We don't have great evidence about how to manage it. These are data from the Cabana trial. Remember, the Cabana trial was published in JAMA a couple years ago. This randomized patients to either catheter ablation or medical therapy. And about 800 of the patients in the trial had a history of heart failure. Most of those who had a normal, who had a known ejection fraction assessment had HFpEF. And this is a post-hoc analysis, so take it with all the grains of salt. But there was a very significant 59% reduction in the risk of the combined endpoint, and also a 43% reduction in all-cause mortality. So this is not the same as a prospective trial. but it's certainly very supportive. This is a very small study, a small mechanistic trial, only 31 patients, but they did the invasive hemodynamic exercise testing to really get at the hemodynamics. They did that at baseline, and then they took one arm and did catheter ablation, and one did usual medical therapy care, and then they repeated it. And they actually saw an improvement in wedge pressure, an improvement in quality of life, an improvement in exercise capacity. So the guidelines say it's a two-way to think about catheter ablation, but more data is coming soon. Coronary disease, very often forgotten in HFpEF patients. We need to be looking for it. When you do look, it's present in about 2/3 of patients have epicardial coronary disease. When you look with more advanced metrics like microvascular testing, it's more like 90% have either epicardial disease, endothelial-dependent vasodilation abnormalities, or non-endothelium-dependent vasodilation abnormalities. So what? What do we do about it? We don't really know. These, again, are observational data. It's a decade old now, but patients with HFpEF who are revascularized had better survival compared to those who were not revascularized. In fact, it was no different from those without coronary disease. So the guidelines give it a two-way. So think about revascularization. Last thing is chronotropic incompetence. Super common in HFpEF. These patients frequently have an impaired ability to enhance their heart rate during exercise, as you can see in these examples, and that change in heart rate with exercise is strongly correlated with exercise capacity. This would suggest that if you gave them a pacemaker to give them more heart rate, they would do better. We tested that in a trial called HFpEF. We gave everybody a pacemaker, and we looked at exercise capacity with pacing on versus off. Pacing led to an increase in heart rate, but it had no effect on exercise capacity. VO2, no difference in NT-proBNP or quality of life. It's because the heart rate went up, but the stroke volume went down, so the cardiac output stayed the same. So pacing is not indicated. So here's the summary of treatment. SGLT2 inhibitor, give it to them. Recommend exercise training or recommend weight loss. I'm going to add the GLP-1RA on here. This isn't going to be on the boards yet, but I think that the evidence is really moving, so this is coming soon, I think. We think about MRAs. We think about ARNIs. We think about PA pressure monitors. I didn't go through that. We don't do things like nitrates and sildenafil. So we stay away from that. We don't do pacing. None of those have evidence. And then we think about treating atrial fibrillation according to AFib guidelines. So with that, I'll stop, and thank you very much for your attention.
Hey, go ahead and have a seat here, Dr. Borlaug. We will move to the Q&A. Let's pull up the first post-test question. So we have, in patients with invasively proven HFpEF referred to the cath lab, NT-proBNP going to be less than 220 in what % of patients? 10, 0, 10, 20, or 60? This talk has become a lot more exciting, by the way.
Yeah.
We have some actual data.
It sure has. It was horrible to give this talk 10 years ago. It's
like, yeah, you have HFpEF. Yeah. All right, 60%. So do you ever get an NT-proBNP? Is there?
Yeah, I think it's still useful to get. And if it's high, it really supports the diagnosis. We've got a paper that's in revision right now. It turns out that if you really want a secure rule-in value, it probably has to be quite a bit higher than this. But I think that if it's really high, and particularly if there's other corroborative evidence, it's helpful. If it's normal, we just have to kind of move on and do more testing.
I've heard of false positive NT-proBNPs in certain, obese patients, things like that. What's your take on that?
Yeah, so people that have right heart failure may have false positive high NT-proBNP, and that's just because it's coming from the right heart. Or people with CKD, particularly people with really low GFRs will have it. And then, there are some people who it goes up with aging, of course. So, an older woman with some CKD, she may have an elevated NT-proBNP in the absence of heart failure.
Got it. Okay, but a lot of false negatives.
A lot of false negatives. So that's, these question writers always have sort of an agenda. So my agenda was to really make sure that you all do not use NT-proBNP as a rule out.
Got it. Okay, so next question. 60-year-old male has obesity, type 2 diabetes, hyperlipidemia, sleep apnea, dyspnea with minimal exertion, no edema or S3. Can't really tell the JVP. His EF is normal with mild RV enlargement and dysfunction, normal left atrial volume, ED prime 10, PA systolic pressure 60, chest x-ray coronaries normal, mild restriction on PFTs with a normal DLCO. What do you do next? VQ, NT-proBNP, right heart cath with exercise, cardiac MRI, or a PYP. 93% get a right heart cath with exercise. Okay, let's see how this compares. All right, so you take this guy to the cath lab. We've had a lot of questions come up about how do we do this? What's our protocol? What are we looking for?
Yeah, so I mean, you wouldn't necessarily need the exercise this case, you'd see, but I think it would be good to be prepared for it because if the hemodynamics were normal at rest, we would want that. But you can do it supine or upright. If, we do it supine here at Mayo, so it's just a normal right heart cath. We've got a radial arc line and then a jugular sheath, and we get a regular resting right heart cath, and then we get their feet up in the cycle ergometer. It's a supine cycle, and we just repeat the measurements during stages of exercise. And, there's a little bit of a learning curve, and people have said, this is not available, but the number of centers that offer this is really growing now. And I would say it's basically an indicator of the quality of the medical center that you're going to, whether they offer this or not. So I think most people, they have some center somewhat nearby that can do this test. I think a lot of these answers could be supported, but like the board questions, you got to go, which one is going to be the best? Because there's some distractors, like the patient could have pH due to other reasons. We need a cath to know what it is.
And what are you looking for on the right heart cath? Just make sure everybody's clear about numbers and things like that.
Yeah, so, the echo estimated that there's pulmonary hypertension present, but we don't know why. Is it pre-capillary, meaning it's a high PVR, or is it post-capillary, meaning it's left atrial hypertension? So that's the most crucial distinction. And the E to E prime ratio was not that high, suggesting it could be pre-capillary. If it's pre-capillary, it might benefit from pulmonary vasodilators. So that's a major watershed moment, linchpin kind of decision if they've got that. If it's HFpEF, we need to know it's HFpEF so we can get them on an SGLT2 inhibitor and other therapies.
Got it.
If it's pre-capillary, it could also be lung disease or chronic thromboembolic disease. So it's really going to push us one way or the other with the right heart cath.
And let's say the PA systolic pressure was 35 or 40 on the echo. How does that change your approach?
You'd still do this because there's still lots of indicator that this patient has HFpEF. You could say if it's really not that bad and the RV is not dilated or anything, that it's probably not pulmonary arterial hypertension and just treat them for HFpEF. You could probably support that because the pretest probability was very high that this was HFpEF.
So if the PA systolic pressure isn't too high, why not, someone asked, could you just put this patient empirically on a diuretic and an SGLT2 inhibitor and see how they do?
Yeah, I think you could do that. I think you could definitely justify that.
Got it. And then, all right, so we'll get to that.
If the RVSP were lower.
If the RVSP,
that's
the
key.
pulmonary hypertension.
In this case, you would need to rule out, the onus is on you to rule out precapillary pH.
Got it. Okay, let's go to the next question. All right, so 71-year-old woman with history of AFib, breast cancer, PACER, and CABG presents with worsening dyspnea. Jugular venous pressure is 14. There is an early diastolic sound and 2+ edema. Echo shows EF 60% with abnormal septal motion, lateral ED primed at 13, NT-proBNP 127. What do you do? Start spironolactone, coronary engraft, angiography, left and right heart cath, cardiac rehab, or dapagliflozin 10 milligrams daily. See if we can get to 150 here. All right, so 50% said left and right heart cath, and let's see the comparison here. All right, so again, this patient, what are we looking for on the left and right heart cath in this situation?
Yeah, so thank you for really taking home SGLT2 inhibitors. That I'm glad to see that. But I think the concern here is that this patient might have constrictive pericarditis. She has a history of breast cancer, and she's had radiation to the chest, and she's also had bypass surgery. And then she has an early diastolic sound. It's not listed as an S3, so that suggests it could be a pericardial knock. So there's a couple clues here that maybe it's not just HFpEF, that maybe it's constrictive pericarditis. And again, we need to rule that out because it's going to fundamentally change management. And we can cure her with a pericardiectomy if that's what it is.
I think the tricky thing in these HFpEF patients is teasing out the HFpEF from the dyspnea related to the other comorbid conditions, because inevitably these patients are going to have some, they're obese, they've got COPD, they've got some renal failure. How do you approach that? Like, is it HFpEF or is it non-cardiac dyspnea? Because I think that's what because oftentimes primary care will send a patient, you're short of breath to us, what's going on?
Yeah, I think that's another situation where the invasive assessment is really key because it's just, that's the objective. It comes back to that Brown-Wall definition, inability to pump without high filling pressures. And when you see the high filling pressures, you can't argue with that. If you don't, then it does support more that it's COPD or something else. Because these things are usually pretty multifactorial.
Yeah, and how do you support, deconditioning into, how do you factor that into the differential for HFpEF?
It's kind of a garbage term, actually. It's just kind of a garbage basket just to say that it's due to decondition. I mean, lots of people are deconditioned. Patients with HFpEF are deconditioned.
Absolutely.
People with all chronic causes of breathlessness are deconditioned.
Yeah.
So, there are certain things that you can see with the invasive assessment. Sometimes they have a low AVO2 difference with exercise because their muscles aren't tuned up, so they don't extract oxygen very well, and that supports that. But it's more of a garbage term, I think.
Okay, that's helpful. So Dr. Miranda was talking yesterday about, he gave the hemodynamics lecture and said that LVEDP and wedge pressure are not the same thing.
That's right.
But for your purposes in evaluating these patients in the cath lab or clinically, is LVEDP an adequate surrogate for the wedge?
Yes, I think that, so LVEDP is often higher than the wedge pressure. So it usually corresponds to the peak of the A wave. And we measure the wedge pressure at the midpoint of the A wave. And people who have very stiff ventricles and high viscoelastic stiffness will often have a very high end diastolic pressure. So people like hypertrophic cardiomyopathy. So in them, it may be much higher than the wedge. But if it is really high, that usually is supportive. So I think, we say 15 wedge at rest, 25 with exercise, and that's pretty much what we say with the LV. We used to think that doing an LV EDP with exercise was better, but actually it's not, because it becomes really difficult to say what is the EDP when the patient gets tachycardic. You got a fluid-filled catheter instead of a micromanometer. So the wedge really works better. Plus you're getting all this ectopy because they're breathing fast and your pigtail is running into the endocardium.
Okay, good. All right, so last question here. A 60-year-old woman is hospitalized with heart failure, markedly improves with IV diuretics, and is discharged on furosemide 40, a 12, a 10, lisinopril 10. Now reports dyspnea walking one flight of stairs. EF is 62 with an RVSP 65 and mildly dilated IVC, moderate MR, BMI 32, blood pressure 126/76, heart rate 72. JVP 10, clear lungs, no gallop, soft apical systolic murmur. What do you do? Spironolactone 25, sildenafil increased to 20 if tolerated. DAPA, discontinue lisinopril, start an ARNI, TEE, or semaglutide. Okay, 85% said start DAPA 10. Let's see what this. Okay, so clear benefit. I think you showed the data from DAPA. So maybe next year when we have you back, do you think semaglutide might be on the list too?
Yeah, it might be, because now we have two trials in STEP-HFpEF and STEP-HFpEF-DM. We have the SELECT trial remember the SELECT trial was people with cardiovascular disease, but there's going to be a heart failure specific analysis from SELECT that will be coming soon. It's going to be presented, I think, at ESC. And then there's Summit. I showed you that's tirzepatide. So I think the landscape is really changing rapidly here, but we're just not quite there right now where we can do this. Insurers won't pay for it. It hasn't been approved by the FDA for this indication. CMS won't reimburse for it. So, and there's national shortages. So yeah, I mean, it's not quite there, but I think that's where we're headed.
We're getting there, yeah. And then spironolactone would be your second agent.
Yeah, spironolactone would be very appropriate. It's just that you would start the SGLT2 inhibitor first. And then, the sequencing would be the DAPA, then the spironolactone, and then if they were still symptomatic, then we would think about switching the lisinopril to sacubitril valsartan.